So we'll be starting with the case. The first vignette I'll show you. Usually in the exam, you'll get 10 minutes, first 10 minutes to read this vignette and
Okay.
then go ahead with the questions. You can make notes and just prepare yourself for the exam also. But here
Oh,
directly we'll be starting the Viva. So you can read out the case.
okay.
Yeah, I'm showing you the labs of this patient. Just have a look at this.
Yeah.
Okay.
Uh, yeah. I'm seeing still
Yeah,
92 Europe. Yes,
this is the blood gas.
0.9. Okay.
We'll start with the questions. The first question for this is, can you please summarize the findings in this case?
This patient came with acute decompensated heart failure, liver failure, and he has ascites, also anemic. His WC's count is elevated, and thrombocytopenic, severely acidotic, severe metabolic acidosis, lactic acidosis. Uh, and it's just is dropping. Most likely hepatic encephalopathy.
Yeah, very good. What immediate management does this patient require?
Uh, this patient, first of all, I have to maintain his ABCD.
Very good.
I will see the airway, the priority for airway if he need intubation or no. Especially he has variceal bleed, superficial varices. Maybe he's has hematemesis or something like this. Also maintain hemodynamics, breathing hemodynamics. I will put large bore cannulas and start him resuscitation if he's shocked. Also, his acidotic 6.9 is severely acidotic. I will give him transiently bicarb now because he's 6.9. Um, Also, will send
Any
for
more?
him
Any more?
cultures. Huh?
Any more? I mean, any more? Only the immediate management, not the long term or no,
Ah,
immediately what concerns are there in this and immediate you need to correct in the research itself.
will correct his acidosis mainly and airway, secure his airway and maintain his
Yeah, that
hemodynamics.
is
Yeah.
okay, fair enough. So, how will you classify his liver condition currently?
According to child score, he will be child C. His He has hepatic encephalopathy. He has ascites and albumin low, bilirubin elevated, and according to child score, will be child C.
Any more classification can you think about his present liver condition?
Mild score.
Okay, okay, okay. Fine. Why is important to classify the liver failure?
Uh, to see if he is candidate for liver transplantation or no, and to assess his survival rate, chance of survival, life
Yeah,
expectancy.
yeah, fine. What are the etiologies of acute liver failure?
Acute liver failure is can be because our case like alcoholic, viral, infiltration, viral include B and C, also amyloidosis, also uh, liver failure of like bilharziasis, others.
Any more the common few more common causes of
HCV,
yeah, very good.
HCV, yeah, viral, yeah, it's B and C, and bilharziasis, alcoholic infiltration, lymphomas,
Okay, okay.
sense.
What is the pathophysiology of hepatic NCAF in ALF?
Again, please.
What is the pathophysiology of hepatic encephalopathy in ALF? Why does hepatic encephalopathy occur in acute liver failure? What is the pathophysiology? Few points.
Pathophysiology is yeah, in liver failure, the liver cannot get rid of ammonia, and it will pass the
Mohammed
blood-brain
Hamza,
barrier,
it's not your time
and
to
will
enter.
cause
Then I'll tell you the
will
scheduled time. Please enter that time.
mainly the ammonia
Sushmita,
will
can you
cause.
switch? Sorry, 1 minute. Man. Sushmita, can you switch off your audio, please? It will disturb the candidate. Yeah, Dr. Ahmed, sorry for that. Yeah,
Yeah,
please, you can
yeah,
continue.
sure, no problem. Mainly the ammonia, with liver failure,
Okay,
ammonia cannot
ammonia
be.
is causing.
Yes, yes.
Okay, okay. Uh, what is the role of the liver protective measures such as N-acetylcysteine, branched-chain amino acids, and lactulose
Hello.
in acute liver failure? Do you
Uh,
know
ال-
any
ال-
these things are
yeah,
given?
and acetylcysteine is a problem with hepatic encephalopathy is NAPKI in the products. It will get rid of this NAPKI product, and also lactulose will get rid of ammonia from the GIT. Will help to increase the
I'm just
number of
asking
motions.
you, I'm not asking you to explain it. I'm just asking you whether there is a role of these things or not in liver failure. Means in a patient of liver failure, should
No,
you?
and acetylcysteine has role in acetaminophen toxicity.
Okay. And
If I am suspecting
others, branched-chain
uh,
amino acids and lactulose?
yes, lactulose, yes, and branched amino
Okay.
acid, uh, Lola,
Okay. Yeah,
yeah,
yeah.
yeah, also Lola.
Okay. Okay. Now, in the second minute, now this patient is transferred to you in the ICU. Now you are managed in the emergency. An aseptic screen to include an ascitic tap is planned for this patient. Okay.
Yeah, yeah.
Describe the process of carrying out an ascitic tap. How will do a ascitic tap for a patient, for this patient?
Yeah, this patient will be a complete aseptic process.
Okay.
Will bring the ultrasound to be ultrasound guided. Will see by the ultrasound where is the largest bucket to take the aspirate from it. يعني uh, and also the needle. We'll do a aseptic technique يعني with needle and ultrasound guided.
Okay. What test should be should the ascitic fluid be sent for?
We'll send for cytology and for culture and for cell count and chemistry. We'll send protein and glucose and يعني chemistry, full chemistry, triglycerides and pH and all of this stuff. YPCs.
Okay, okay. How will you diagnose a spontaneous bacterial peritonitis on the basis of these test results?
This is depend on the YBC's count. If above 250, it will be diagnostic for spontaneous bacterial
Yeah.
peritonitis.
How would this differ in tuberculosis ascites?
In tuberculosis, if acid fast bacilli is if there is Zillner stain.
Yeah, any more thing which differentiates, which is specifically seen in tuberculosis ascites?
I think it will be more turbid. Not sure.
Okay, okay. Now, third minute, the patient has an ascitic WBC count of 1,800 and the diagnosis of SBP is made and the patient is commenced on piperacillin tazobactam. Now, my
Okay.
next question is, what further investigations would you consider?
Further investigation will send for him culture systemic cultures. يعني since beginning we have to send cultures also.
Okay.
Uh,
Any more specific investigations? In this case, what you would like to do?
endoscopy also if he has varicose bleeding need any banding. Also alcohol level. Uh, search for any alcohol يعني toxins.
Okay, okay. Now, the last minute, the patient has an abdominal ultrasound. This reveals a liver with a severe cirrhosis and no evidence of hepatocellular carcinoma or portal vein thrombosis. The kidneys appears to be normal. Patient has a baseline creatinine of 74 micromoles and which is now 220. Okay. The patient's
Okay.
vasopressor requirements continue to increase. The acidosis continues to worsen.
Okay.
Now, my next question is, what are the likely causes of acute kidney injury in this patient?
Uh, First of all, of my mind will be hepatorenal.
Very
Uh,
good. Anything
Hepatorenal
more?
symptom. Yeah, it can be pre-renal from
Yes,
sepsis.
yes.
Yeah, hypovolemia, anemia. Uh, uh, hepatorenal also يعني it can be any cause of renal failure itself. يعني if pre-renal, renal, and post-renal also any obstruction, compartmental syndrome
Very
in
good.
the ascites.
What are the diagnostic criteria for hepatorenal syndrome?
Hepatorenal syndrome, patient has acute liver failure and ascites. Is not hypovolemic. We exclude hypovolemia from the diagnosis. Also, the kidneys by ultrasound were normal, and then sudden drop in يعني sudden deterioration in renal function. Hypoalbuminemia.
Okay, okay. So, how will you manage a hepatorenal syndrome?
Hepatorenal syndrome, we need something to cause a splanchnic vasoconstriction. We can use norepinephrine and correct hypovolemia with albumin. We can use also terlipressin, and before also we can use midodrine and octreotide both together. But يعني norepi or يعني terlipressin preferred with correction of hypoalbuminemia. Uh, if failed, we can use tips.
Okay, okay. Fine enough. What are the characteristics of patients with acute liver failure which warrant liver transplant? So, what are the things which will warrant you to take the patient for the liver transplant?
Uh, there is score for him. يعني life
Yeah.
expectancy will be more greater than 1 year, and not to be child C. يعني if child A and C and B. Not
No, what is the score for this liver transplant in acute liver failure?
if INR INR above 6 and also
Okay. What is
bilirubin.
what is this
Mm,
criteria called?
um, the name I forgot the name.
Okay, no problem. What is the criteria you can describe?
It's including INR and creatinine and bilirubin and life expectancy above يعني more than 1 year. Child A or C or B.
Okay, no problem. What alternate criteria for risk prognostication in acute liver failure? This criteria you told, na, INR and bilirubin, creatinine. Any other criterias do you know for risk prognostication in acute liver failure?
In Apache or Apache 2.
Yeah, any more? Okay, no problem, no problem. Are there any specific disease-oriented therapies in acute liver failure?
Disease-oriented therapies in
Yeah,
acute tips,
okay.
transjugular intrahepatic portosystemic shunt.
Yeah,
Uh,
any more specific uh, therapies what we can give in few type of patients in acute liver failure?
therapies.
Yeah, no problem. Okay, we'll move forward. What is the role of steroids in acute liver failure? Can you give steroids in acute liver failure?
No role for steroids.
Okay, fine. Okay, I think most of the answers you've done correctly. We'll move forward to the next part of this exam, that is the CBS. I'll give you 5 minutes for each table. In each table, there will be 5 questions and 6 questions actually. Let me see how much you can, 1 minute for each question. But if you are quick, you'll get the sixth question also. Okay. Should we
Okay.
start? Should we
Yeah,
start?
sure. Okay.
You need a break and all or something? Should we go ahead?
No problem. We can go on.
Okay. So first we'll do the curves. There will be 6 questions. One only suggestion from my side is be quick, be up to the point, and if you don't know, you can pass. If you have time at the last, I will come back to it. While in CCS, we cannot come back, but in CBS, if I have time, you have not answered that question. If you're wrongly answered, it will not come back. But if you're not
Yeah.
answered, I'll come back to the question. Okay. So the
Okay.
first question in the curves is list 3 measures that are used in the management of this condition indicated by the following ECG.
Yes. I can see here Osborne wave. This related to hypothermia mainly, and he has
Okay.
يعني, this is sinus rhythm and good rate, and his axis is normal. Measures we have to do rewarming of this patient because he has hypothermia. Uh, we'll send the thyroid screen also to search for the source of the hypothermia. You mean rewarming measures? 3 rewarming measures?
Okay. This patient is being ventilated on FiO2 of 0.9. What type of pulmonary deficit is suggested by the ventilatory waveform displayed below? List the causes of this pattern of pulmonary deficit.
He has hypercapnia due to hypovolemia, hypoventilation.
Yeah. So, list the causes.
Hypoventilation and
Okay.
decreased level of consciousness.
Okay. Good.
Bronchospasm also.
Comment on the arterial line tracing. What test will you use to confirm this finding, and what are the common causes of these waveforms in the ICU?
This is you can see underdamping, overdamping. Sorry, overdamping due to kinking clots in the line. We'll do flush test.
Flush test. Any more name for that test? Specific name is there? You're correct.
Yeah.
There is specific name for that test. Any more? Do you remember?
We'll do the
Okay.
the
Fair
flush
enough.
test. Yeah.
Fair
Yeah.
enough. No issues. Good. Identify the image. What is the advantage of this technique? What is this going on?
This is a high frequency, the ventilation, high frequency volume.
No.
Identify the image and what is the advantage of this the technique.
Can you think of anything more? What is this? This is not high frequency ventilation. Sorry.
I can skip for now.
Okay, fine. Fair enough. Comment on the report of a post-operative patient with persistently high drains for the past 1 hour. What is this and what is the abnormality?
This is thromboelastography, and this is hypercoagulable state, prolonged clotting time.
Prolonged clotting time. Okay.
Yeah.
Comment on the red form shown in the monitor. What are the hemodynamic changes that occur with augmentation, and how do you time the augmentation? What is the red
This is
thing?
intra-aortic balloon.
Very good.
Intra-aortic balloon pump. This is a rate of 1 to 1, bit 1 to 1, and this actually I can see this is delayed inflation, delayed deflation.
Okay.
The inflation is okay.
How do you time the augmentation?
The augmentation timing will be at the middle of T wave.
Middle of
T wave on the ECG.
Specific phase where you do that augmentation, where it should augment the balloon.
During the stall, at the beginning of the stall, on the T wave.
Okay.
Yeah.
Your time is over. We'll go to the images, the first images. This is a young lady was crossing a busy road, hit by a car, and have severe traumatic brain injury. CT after 24 hours into the ICU admission. The ICP is 30. List your possible management strategies.
This CT brain showing diffuse brain edema and right front to parietal intracranial hemorrhage, and I can see the midline shift.
See, what the question is, list your possible management strategies.
Yeah,
question is not to describe the city.
Okay, we'll do ABC. We'll secure her airway and maintain her breathing and maintain hemodynamics. We'll start her with.
Sorry, Dr. Ahmed, this is a mock test, that is why I'm here in the exam. Specific, be very specific. They have asked her ICP has raised to 30. What is your possible management strategy?
ICP 30, we have to urgently call the neurosurgical consultation and give brain dehydrating measures like mannitol and hypertonic saline.
You should be very specific.
But mainly the neurosurgeon.
Don't go on describing.
Yeah.
Okay. What is the most common cause of the principal abnormality seen on this scan?
There is pancreatitis and calcified this pancreas, calcification on the pancreas.
What is the cause?
Pancreatitis.
Yeah. So the question is, what are the most common causes of this?
Alcoholic and gallbladder stones. and
Good.
infiltration of the pancreas also.
You should
Tell-
concentrate on the question, not only on the image. Okay. What they are
okay.
asking. It's not always they will ask what is the image.
Yeah.
So this is the 69-year-old patient started on CVHD, admitted through ED with acute CRF, and the patient has been hypotensive tachycardic since admitted despite several intravenous fluid challenges. There is no fever. Patient is mildly confused. Echo was done to try to clarify the cause of hypotension. A still image of a subcostal view. What pathology is demonstrated, and list 3 possible causes in this patient.
Here there is pericardial effusion, also the dilated left side, يعني, but it has to be moving picture. يعني.
36-year-old patient, day 5 of his admission to the ICU following witnessed collapse. The Fisher grade is 3 SH. The level of consciousness deteriorated from withdrawing from a central noxious stimulus to extension to the same stimulus. Pupils remain sequel reactive to light. EVD does not appear to have increased output rate. Following investigation is performed. What is this investigation? What does it demonstrate? List 3 management options. Very briefly, very
This is
briefly.
transcranial Doppler
Okay.
showing
What does it
increase
show?
vasospasm.
Okay. How will you manage that?
Intra will with nimodipine and intra nimodipine and IV also calcium channel blocker.
Okay. Okay. This patient presented with dyspnea, required intubation for respiratory distress. Intubation was difficult. Identify cause for this.
Cause of difficult intubation.
Yeah.
The tube is esophageal. I can see only the central line is left IJ and
Okay, your time is over. You could not complete. One more question was there. Okay. Now we'll move on to the biochemistry part. Just a minute, I'll try to. This is the first question of the biochemistry. This is a 59-year-old lady on the ward recently treated for painful active rheumatoid arthritis, awaiting completion of discharge planning. A med call is put for a witnessed collapse that occurred. She got up to use the bathroom. The first intravenous volume bolus has not improved her blood pressure. What therapy would you consider next? Okay, these are the labs given. From the labs, you have to tell what next therapy we have to give to this patient of hypo.
yeah, urea 11 and sodium hyponatremic on 27. Uh, what the CO2? Bicard, this is the Bicard 21. PO2 1 serum osmolarity 2. This is hyponatremia and also the urine osmolarity increase and urine sodium. Most likely cerebral circulation, fluttercortisone.
Question is, what therapy would you consider next for this patient having hypotension?
For hypotension, we give the bolus of fluids. We'll start norepinephrine.
Start not. Okay. This is a 48-year-old gentleman brought to the ED via ambulance. He was found in the parkland confused. His observations are as follows: heart rate 107, BP 98 by 56, respiratory rate 26, saturation 94%, temperature 35.6. What further test would you request? These are the labs. You can have a look and tell me. Dr. Ahmed,
Yeah,
your
he's
time is
hyponatremic.
running. If you don't know, because it's last 1 minute, 4 minutes you have wasted, only 2 questions. If you
Uh,
don't know, we can skip.
yeah, you can skip this.
Yeah, you should say that. Nah, this is the time is over 5 minutes, but still I'm giving you one more question. The 34-year-old lady admitted with fever, altered behavior, rapid decrease in level of consciousness, necessitating invasive airway support, has been noted to have a urine output consistently greater than 150 ml per hour. Lumbar puncture is performed along with biochemistry is displayed. What is the diagnosis? These are the labs. You can see the results are given, and what is the diagnosis for this lady?
She is hypernatremic and hyperosmolar, high protein in the CSF. This is bacterial no organism seen.
Okay, your time is over. Okay. Thank you. You did well, but I think one or two things I just want to say is be very specific. Don't go on describing the images or things what you are seeing in the uh, CBS. Read the
Yeah,
question. If they are asking only about the management, they want only about the management. They don't want to know what the ECG is showing, what is the P wave, what is the QRS, what is the Osborne wave. They
yeah,
want to know only what you have to manage. If it is asked what is the diagnosis, at that time you can tell them that this is the diagnosis. So concentrate on the question. CCS you
yeah,
have done well. CBS few questions, and just try to manage the timing. The most important thing in EDIC 2 is that it is a race against time. In
yeah.
CBS, you have to be very quick. If you don't know, you have to pass it on. You could complete only two questions in 5 minutes in biochemistry. The
Mm-mm.
further questions would have been easy. You lost that only because you concentrated, gave more time on the difficult questions, and you were unable to attempt the easy questions. So you can say
Yeah,
pass. You can come back on that if time is left. Okay.
yeah, yeah. Skip the one. I will have time for. Yeah, yeah. Sure.
Okay. Okay. Thank you. Thank you, Dr.
Thank
Amit. Thank
you,
you.
Dr. Deepak. Thank you so much.